Hi, this is Brian Wormers from the University of Sioux Falls, and today I'm going to be talking about asthma from this PowerPoint lecture of asthma and COPD. So our learning objectives, so we're going to talk about asthma and of course COPD, and we're going to jump right into it here. So incidence and prevalence, so realize that this is intermittent inflammation of the mucous membrane. So intermittent is keyword for this one. And it's in response to allergens, irritants, microorganisms, aspirins, NSAIDs, or it can be a hyper-responsiveness related to illness, exercise, or other idiopathic reasons. So it's going to occur at any ages, but very young and very old are most susceptible to this. It's about 8% of the population. And in adults, interestingly enough, it's more common in women than men, but in children it's more common in boys than girls. So what happens is you get exposure to a trigger, inflammatory response with increased vasodilatation and capillary permeability, which leads to edema and mucus production, and then airway thickening and broncho hyper-responsiveness. So I know that Sherry will talk about this and say that there's three different legs of the stool with this one, and so it's inflammation, edema, and mucus production. So subjectively, they might have bouts with dyspnea, tight chest, coughing, wheezing, and an increased mucus production. And they might have other allergic signs and symptoms, such as rhinitis, pruritus, or eczema. So those with some of these allergenic problems are at a higher risk to have asthma. And oftentimes we'll see them all together. So if they've got a rhinitis, eczema, and asthma, that's kind of a common thing to see that triad together. So history may include smoking or smoke exposure, or be positive for family history of somebody with asthma. Objective, what we might see is barrel chest and somebody that's chronically air trapping. That's not something we normally see with asthma, but it's potential. And then during acute episodes, we're going to see audible wheezing. So remember that this is expiratory wheezing. Inspiratory wheezing is called stridor, and that's a different mechanism. So expiratory wheezing is notable with this. They're going to have a prolonged expiratory phase in their respirations. They're going to have some tachypnea, coughing, difficulty in communicating and talking, some cyanosis maybe, tachycardia, and changes in level of consciousness towards late stages. Labs and diagnostics, so ABGs can assess for gas exchange within the body, and so you might see that some changes within that. You might see IgEs elevated related to allergic components. You're going to see sputum production related to eosinophils and things like that as the body's fighting off an allergic reaction. Might do pulmonary function tests. This is using a spirometer and measuring the airflow. This one, the forced expiratory volume 1, is probably one of the most important related to this, and it's just seeing how much air that they can exhale in 1 second. And then a chest x-ray showing hyperinflation of those lungs is also something you might see. Planning implementation, so risk for impaired gas exchange, and so some of the things that we want to do is help them with this, of course, and optimize their breathing. We can do that with self-management education. We can describe the daily controller drugs, use peak flow meter. With that, we want to kind of see, what is their best, what's their minimum. We can put it into different zones. And if they are at that red zone, which is less than 50% of their best or their baseline, they should probably seek help with that. We can also keep a diary of symptoms and interventions if they are constantly or getting sick at the same time of the year each year. Maybe we can look at the allergens during that season and maybe help them avoid that, and then avoid those triggers as possible. Some other nursing diagnosis, so risk for impaired gas exchange. What we might see with this one is trying to increase their breathing, increase their gas exchange. And so some of the things that we can do, of course, is drug therapy. There are controller drugs out there. We can use that on a daily basis, and that would be more like Singulair or maybe even long-term or long-acting beta-2 but we'll also use reliever drugs, and that's like your short-acting beta-2. So albuterol is an example of that one. So here we go. Bronchodilators, short-acting albuterol is one of those main keys. You can have longer-acting one like salmeterol or Ceravent, but it's not commonly used. There is a black box warning on some of this, in the fact that if they use these long-acting ones for a long period of time, if they get into trouble and they try to use a short-acting one, usually the short-acting one is not beneficial then. So we do try and stay away from the long-acting ones at time for asthma. So with this one, we can also use Atrovent or Spiriva. We can also use Singulair, or we can use some inhaled steroids type of situations like Pulmicort or prednisone. So you kind of see that we do have different ones for controls and then relievers or exacerbations. So we can talk about risk for impaired gas exchange related to ventilation and perfusion. So with this, of course, we're going to talk about this, strengthen those muscles, maintain cardiac health. We'll do some oxygen therapy as required during an acute exacerbation. And then we do need to monitor for status asthmaticus. So if this goes on for a prolonged period and it's life-threatening, then this is a serious thing. And so this, of course, is going to be a hospitalization, and we need to monitor it and treat it appropriately so it doesn't happen again. So with this, you can kind of think about this. So what parameters include the nurse, indicates to the nurse that the short-acting beta-2 agonist took 5 minutes ago is effective. And so what we're going to probably see is not that they decrease in this, but their peak flow rate will increase, and hopefully they're not using the accessory muscles anymore, and they're not having, active bubbling, humidified chamber will happen regardless. So B would be your correct answer for this one. That concludes this part of the lecture for asthma, and please go on to the next recorded video to learn about COPD.